Thank you, Angie. It's a pleasure and a privilege to be participating in the workshop today. As Angie introduced, I'm going to be speaking about breast cancer in the fall, which is Breast Cancer Awareness Month. It's really 3 months long, at least in my life. I'm going to be speaking about Affymetrix gene expression profiling, principally, and most of our work has been on the U133 platform. We'll be talking about some of the newer platform work at the very end. And in terms of relevant disclosures, I just want to point out that Nuvera Biosciences is a small bioinformatics firm that is associated with MD Anderson, and Christos Hartzis and Nuvera and myself have co-developed some signatures, and therefore that conflict needs to be pointed out and understood. Okay, so this is from a talk I gave at ASCO a few months ago. I pointed out where we stand with precision medicine right now in breast cancer. And the way the data are organized, on the rows are the clinical questions for breast cancer. On the upper columns in yellow are the main principal phenotypes of breast cancer. Hormone receptor positive, HER2 negative, about 60%. HER2 positive, about 18%. Triple negative, about 17% in terms of prevalence. And then below that is the stage of disease at the time of testing and treatment question. Stage 1 being very early, stage 4 is obviously metastatic, very different questions there. And where there's a check mark, there's a test that is clinically available. Okay? The number below it is the number of tests that are available in that space. So if you take at the bottom, susceptibility, think of the Angelina Jolie story. BRCA mutation testing as a risk assessment is present across all phenotypes. It's obviously most relevant to triple negative, but because it's a risk assessment tool, it's across all phenotypes. So that's one test. In the natural history, where you might potentially consider no systemic therapy at all, we have the MammaPrint, but people don't really use it for that indication. For very low risk of early breast cancer, if you give hormonal therapy, we have Genomic Health, we have PAM50, we have MammaPrint, and we have a couple of others as well that have reached clinical utility. And some of them are also, by default, being used to answer the question as to whether or not chemotherapy is indicated due to super low risk of relapse if you just gave hormonal therapy by itself. Okay? HER2 positive, the test there is simple HER2 testing. FISH, immuno, both. And so essentially the main point here is that in breast cancer, all of our eggs are principally in one basket, which is the most indolent, least aggressive form of breast cancer. Stage 1, possibly early stage 2, hormone receptor positive HER2 negative disease. And for most of the types of breast cancer, we have actually no tests. They're the harder problems to solve. We need multiplex assay platforms. We need strong clinical and translational models to be able to develop predictive and prognostic tests for those settings. And I wouldn't steer away from hazarding a guess that in pretty much all the major cancer types, this is the issue. That we have a bunch of tests for a minority or a clinically least worrisome population. There's plenty of scope in cancer for improved diagnostics. So I'm just going to give you some overview of how we're taking on that chart with our translational research program. The first work is regards the sensitivity to endocrine therapy index. We know that at the transcriptional level, the major determinant of overall transcription is estrogen receptor activity. Okay? Essentially, it sets up a tidal surge of multiple waves of transcription that define the transcriptional profile. Many of the most co-expressed genes are themselves transcription factors. Okay? So for this, we took on a simple bioinformatic approach, which is to say we want to know the transcripts that most robustly represent estrogen receptor gene expression itself, with the assumption that they are the downstream transcriptional product that is either increased or decreased as a result of ER activity. And we optimistically called it the sensitivity to endocrine therapy index, or SET. We used a cohort of a couple of hundred patients on the left to prove the principle, and we committed that entire patient cohort of hormonal therapy treated patient samples with long-term follow-up. We used that entire population to define the thresholds for high, intermediate, and low, and we censored everybody at 8 years so that we'd catch the 5 years of treatment and the 3 years thereafter, and we wouldn't be looking at long-term prognosis. We then separately and independently evaluated another several hundred patient cohort to see whether those predefined thresholds with that predefined index were prognostic for patients who received hormonal therapy. And as you can see, those who in green who have the high set index, the high ER-related transcription, clearly have an improved long-term prognosis. Okay? And so it's a proof of principle, and it's an independent validation of that principle. And it's a pathway-related transcriptional output that we're attempting to classify and measure. This index has 165 probe sets. The other thing I wanted to point out within this, I left out the slide, is if you look at the validation cohort and if you look at the node negative versus the node positive patients, it works extremely well in the node negative patients. Okay? Now, the other thing with respect to chemotherapy response, that's a lot harder because it's not a discrete pathway that's transcriptionally driven, transcriptionally represented that you can classify and measure. Okay? So there you need to either try to train on long-term prognosis, wherein the prognosis is related to the biology of the disease, the effectiveness of treatment, the effectiveness of any other sequential or concurrent treatments that the patient gets, and as well the timeline of the different phenotypes of cancer. Some take a long time to come back, some come back very early or not at all. Okay? So you have to take all of these considerations if you just take samples from way back and try to then map against survival thereafter. And this will be true for every type of cancer. Okay? There's a lot of heterogeneity at the biological and at the clinical level. When we're measuring out endpoints, we need to understand what they mean in the context of the clinical scenario. So in breast cancer, we use a model. It's a small niche, although the FDA recently approved it for as an endpoint for drug development trials in breast cancer. It's called pathologic response. And the basic cartoon here illustrates the point. You give the chemotherapy after diagnosis. At the end of the completion of chemotherapy, you pathologically evaluate how much disease is left, and that is indicative of long-term survival. The devil is in the details, but that's the principle. That means that you need to be able to do your multi-analyte assay on a very limited sample. And if you can't, don't bother trying. Adjust the methods and the logistics so that your assay will work well in that setting. And it's worth it because there's one variable here, and that is the chemotherapy that the patient gets, so long as the response assessment is meaningful. So we developed a response assessment. It's called the residual cancer burden. It estimates the area of residual cancer, the cellularity of cancer that remains in that area, and the number of positive lymph nodes and the size of the largest metastasis. It puts it together in a mathematical formula. And essentially, for all intents and purposes, all the variables are independently contributing to the prognostic score of the buffered calculation total that you get as this RCB. And you can find it on the web if you Google residual cancer burden breast, and about 28,000 users a year. Well, it's used about 28,000 times a year as an online calculator. Here's how the assessment of prognosis goes in a validation cohort. When you compare hormone receptor negative breast cancers and hormone receptor positive breast cancers separately, you can see that it clearly separates out the prognosis. It identifies a group shown in blue who are resistant within the context of the phenotype of their disease, and it shows a group with no disease left, that's the grey lines, or with minimal disease left, that's the brown lines, that have identical prognosis over the long term. Okay, so you start to understand what the amount of residual disease means, and you can stratify risk based on your endpoint, now you can train predictors of sensitivity and separately predictors of resistance, and you can start to piece all of this together. But first, let's go back to the set index, because patients with stage 2 to 3 breast cancer, locally advanced, who need chemotherapy, they will get hormonal therapy after their chemotherapy, and that may or may not influence their survival. Okay? So you take your signature of the endocrine sensitivity and you assess it with respect to, does it relate to the response to chemotherapy? And that's shown in the table below, and the answer is it was not significant. But then you look at the patient's survival according to that endocrine predictor, and you see that it's highly predictive or highly prognostic after they've gotten chemotherapy followed by hormonal therapy. Okay? Furthermore, it's probably synergistic, because this is an outstanding survival for a fairly locally advanced population. It's better than you'd probably get with hormonal therapy alone, although we don't have the randomized comparator to compare. So somehow, chemotherapy improves your endocrine sensitivity. So in our next round of work, we learned from everything we had done. We realized that if you're going to develop predictors for different phenotypes of disease that behave differently and have different relationships to the outcomes you're going to train on, you'd better train separately within each phenotype so that you have phenotype-specific signatures. Okay? Then you have to understand, in the disease setting, within that phenotype, what's going to affect response and survival. What do you train on? Well, for the hormone receptor positives, there are 3 levels. The level 1 is the sensitivity to endocrine therapy index, like I showed you. The next level is to then train on predictors of resistance to the chemotherapy based on a very poor response or a very early relapse after the chemo. And then the third level in the algorithm is to train on exquisite sensitivity, which is the complete or near complete response that you've already proven determines a very high probability of long-term survival. Okay? And so that's how a multiplex platform, such as the AFI expression system, but any multiplex platform, can be applied to a complex clinico-pathologic therapeutic problem by breaking the problem into the key independent components, solving each of those components to the best of your ability, and then reconciling all of those results into a classifier, an algorithm at the end. Okay, so at the end of this logistic algorithm, you're either predicted to be treatment sensitive or treatment insensitive. So now you take, in our case, a 200-patient study, independently, blindly, the test in that cohort. And here's how we did. Those who are predicted to be treatment sensitive are shown in the red curve. This is a Kaplan-Meier plot, versus those who are predicted to be treatment insensitive. The median survival was 3 years in this cohort. We have other validation cohorts that are blinded that are ongoing, and we haven't seen those results yet, but we've finished the work. There's clearly a wide separation in survival here, and at 3 years and at 5 years, the median disease-free survival, or distant relapse-free survival, was 92% for those who are predicted to be treatment sensitive. This is stage 2 to 3 breast cancer. This is locally advanced breast cancer. In the neoadjuvant model, as I said earlier, we know that response to the treatment in terms of is there any cancer left or is there cancer left is the gold standard. The FDA has actually approved this as an endpoint for drug trial. So let's see how the patients in this cohort did in terms of their actual response 6 months later. And there it is on the right. So you, with a classifier, before treatment ever starts, you can determine in the population the same result that you would get after the chemotherapy is given. Now, what's the difference here? Well, on the left here, you can do something about this information. The patients in the treatment-sensitive predicted group, you can go with confidence into your standard of care treatment. The patients on the black curve with predicted treatment insensitivity are ripe to be introduced to a clinical trial. You can't do that clinical trial after they've finished their chemotherapy. They've done their treatment, the toxicity is going to be advanced, they're tired, it's not going to work. But you can triage patients before they start and provide them potentially with information that will lead them possibly to a better outcome by participating in the clinical trial. And that's going to be our next step forward in our clinical development program. Secondly, if we take the classifier, it was developed in hormone receptor positive HER2 negative subset, that's shown on the left in the validation cohort, and in the validation cohort for the triple negative breast cancers, that's shown on the right. Remember I said there were no tests really for stage 2 to 3 hormone receptor positive HER2 negative? Potentially this is it. There's no test for triple negative of any type. This is applicable to stage 2 and 3 and possibly even stage 1, because chemotherapy is the only treatment they get. In this setting, the black curve for triple negative, 50% chance of relapse within 5 years. I would want to know that. I would want to be able to participate in clinical trials with additional treatments to increase my odds. In the same context, the surgical endpoint, it's becoming increasingly common to use sentinel lymph nodes, where you inject dye into the tumour, you map the draining lymph nodes, and you only remove those instead of dissecting out all of the lymph nodes. Okay? Because that carries with it a risk of lack of mobility and lymphedema, permanent lymphedema or a long-standing lymphedema. And really we're only testing the lymph nodes just for staging purposes. It has no therapeutic intent. So we developed a predictor based on chemotherapy response combined with empirical training on whether or not lymph nodes actually converted to negative status after the chemotherapy. When we had a needle biopsy proving it was positive, the patient has chemotherapy, all the nodes are removed after chemotherapy and everything's negative. Okay? We've evaluated this, and this is a work that's been submitted and is under review. We've evaluated this in lymph node positive patients who started out lymph node positive, and those who were predicted to respond, 60% of them ended up lymph node negative. Okay? Versus those who are predicted not to, 26%. Are these numbers good enough? They're certainly significantly different. Well, that requires further studies and a degree of understanding of how you'd use the data. But this all comes off the same platform. This can be ancillary results in one assay. For the clinically lymph node negative patient population, we know that about 25% of them are actually positive, but we just can't tell that. And for the clinically lymph node negative, those who are predicted to be responsive after 6 months of chemotherapy, 90% of them were negative, whereas those that were predicted not to be responsive, 2/3 were negative. Again, a significant difference. Finally, looking at stage-related changes here, this is about 500 hormone receptor positive HER2 negative breast cancer patient samples biopsied with needle biopsies and profiled on the AFI U133 system. And we're looking at some individual gene signatures, individual genes like hormone receptor, estrogen receptor, and progesterone receptor, a multi-gene index like the SET index. And then on the bottom panel, we're looking at proliferation. We're looking at Ki67, aurora kinase expression, and a 96 gene signature called the Genomic grade index, which is really differentiation and principally proliferation. And you can see that on the x-axis, where we've subdivided the patients according to what stage of disease they're at when they're biopsied, going from stage 1, 2A, 2B, stage 3, and metastatic, stage 4, you can see that there's a little bit of difference in the hormone receptors. There's a significant increase in proliferation. But if you look at the hormone receptor part of it, you see a slight trend for diminution of hormone receptor expression as there's increasing stage of disease. But if you look at the transcriptional product of estrogen receptor, the SET index, you can see a profound decline in hormone receptor transcriptional function according to the stage of the disease at presentation. So potentially showing much more sensitive results as a result of measuring pathways rather than receptors. If you apply that information within the patients with metastatic hormone receptor positive, HER2 negative breast cancer, whose next treatment was hormonal therapy, and you look at their progression-free survival, which is how long they went until the disease next came back, and their overall survival, which is how long it took from the biopsy till the day they died. Okay? You can see clear trends, some of them significant, wherein the ER-related signature, Z index, is independently prognostic, even when you factor in how many times this patient's already had metastatic disease come back, and whether, by clinical definition, at any stage in their course of disease have they exhibited hormonal treatment sensitivity. So you can biopsy metastatic disease and understand the state of play right now in terms of the receptor pathway activity that you're measuring, and you can do it very routinely. And I think this is actually a potentially very promising approach. The one below it is the PI3 kinase gene signature, okay? Not the mutation status, but the PI3 kinase pathway-related genes. And you can see that that too, even with hormonal therapy alone, is illustrating prognostic utility. So don't forget pathway activity, and don't forget that multiplex expression platforms can capture this in a clinically meaningful way. So let's return to our state of the union in terms of clinical genomic testing for breast cancer. This is what I showed you earlier. This is conceptually in the red arrows what on the AFI U133 system, based on our current work, that we could provide from a single assay of a single patient sample at a single point in time. We certainly can improve the coverage for the patient population and for the clinical indications. The next steps, last few moments, I think for this program before clinical implementation, are to refine analytical performance and to continue to improve the bioinformatics specifically for that. Clinical validation studies, I mentioned some of them are going on already in a blinded fashion. We also have a prospective 500 patient registry study that's 80% completed, and clinical utility trials where we actually test the test by randomizing patients to receive the result and have their doctors act on the result versus not receive the result. Still be tested but not receive the result. And therein we'll be able to learn to what extent providing a test can influence actual outcomes for patients. And I think at the end of the day, that's what we need to do in this field in the right clinical models. We'll use the neoadjuvant model for that. And then clearly, I think I'm a pathologist and therefore I'm fully aware of FFPE since I'm immersed in it on a daily basis. This is obviously something we need to address, and on the expression side, I think it's very complicated, but I think I'm actually very optimistic. So what I'm going to show you here as we wrap up are RNAseq. Okay, I'm not a deserter here. I just want to show this is a very interesting model for understanding the effects of formalin fixation on tissues. What we've done, we've got 9 breast cancer samples. They were minced and randomly assigned to either RNA later for fresh, frozen, or FFPE. Each tumor underwent Illumina, HiSeq, NGS twice in both formats. So we've got technical replicates and we've got exact comparisons of fresh and paraffin for each of 9 tumors. Okay? So 9 times 4, what's that, 36 experiments here. This is multidimensional scaling. This says of the 100 million reads per sample times 36 samples, what is fundamentally different? What are the top 2 parameters that fundamentally separate and distinguish what's different amongst these 36 experiments? Okay. Dimension number 1, preservation. Notice that all the fresh frozen are on the left and all the paraffin are on the right, and notice how far apart they are. Okay? This is the biggest problem for expression. We get the assay. The assay works beautifully in FFPE. I'm showing you results from it. We're very happy with the fact that it works. And on the arrays, it lights up like a night sky in the southern hemisphere. It's gorgeous. However, are you actually getting what precision you're expecting? And RNAseq will help us with this. Second dimension, hormone receptor status. Remember, it's the fundamental influence on transcription in breast cancer. You can see the hormone receptor positives widely separated from the hormone receptor negatives in the fresh frozen samples. And on the FFPE, yeah, it's there. But if you were trying to discover, you would identify that hormone receptor status was important, but you wouldn't be seeing it in the huge difference that it is at a biological level because of this artifact of preservation influencing your assay results. Let me illustrate this visually. So the biology signal is blunted, and the biggest problem is preservation. Let me illustrate this. One of the cases, pairs, these are the fresh frozen pairs of Illumina HiSeq. We're looking at estrogen receptor gene expression, ESR1. The counts per million are shown. I'm just up here, the 4,500 on the left is showing the peak, okay? Peak number of reads, 4,500 is the highest peak. And you can see each exon beautifully represented. You can see, of course, the intronic regions have hardly any reads because it's transcript, right? So the matched paraffin of the same gene, of the same tumor, there it is. That's where RNAseq is so helpful. You can see they're all mapped reads, but with this you know where they should be. They should be at the exonic region. There is so much misreading going on that you can barely identify the exons from the noise. Okay, and we've looked at hundreds of genes. Some of them look pretty good. Most of them look like this. Okay, so there's a challenge here. And you can see that there's 1/3 as many reads at the peak level in the FFPE match sample. Okay, so we have a big challenge in expression, and don't think that this isn't happening in DNA as well. But in DNA we're focusing on detection. Does it really matter how many we measure? Well, yeah, it matters, but it's not crucial. With RNA expression, precision matters across the full scale. Okay, so to start to address this, we're very enthusiastic about this study. It's a pilot study, and this is the work is going on. It has actually been done, and the analytical work is going on right now. So we're looking at fresh versus FFPE. We're looking at AFI U133A plus 2, the new HTA2 arrays, which in concept and in theory can be superior for the problem at hand. And we're looking at Illumina HiSeq RNA sequencing. And for each one, we're doing 2 U133, we're doing 2 in the fresh and 2 in the fixed. So we have a factorial design with preservation quality, crossed with genomic platform, crossed with technical replication. And we're very hopeful that this study design will lead to clear insights as to how to translate expression data and where to put the investment in terms of getting multiplex genomics into paraffin in a meaningful way, in a way that can be done on a high dimensional scale to meet the clinical needs that we have to be able to have multiple signatures for multiple disease clinical indications within multiple phenotypes of a single disease, and to be able to do that for different diseases all on the same platform. So with that, I just want to close and thank many, many collaborators, but to principally point out the role of Christos Hartzis at Nevera and now more recently at Yale as leading our bioinformatics group. But as you can see with these translational studies, there are a lot of important collaborators who I don't have time to mention or describe. Thank you very much.